Hello, thank you very much for joining us. This is Platform on the network service of the NTA. I'm Ruth Aguele. Now, today we look at one of the most critical issues in health. Now, issues that I know we must talk about because of its obvious reasons, because it concerns you and I. But the reality is that many people are infected by a disease and some are actually living with it. Many have died from the virus. I'm talking about HIV and AIDS. According to Nigeria AIDS Indicator and Impact Survey, an approximated 180,000 adolescents and young people live with HIV, with prevalence high among females. Now, the survey also shows that very low level of awareness of positive HIV status is low among adolescents and young people, which reflects the low rates of HIV testing. Therefore, targeted HIV programs are required to curb HIV transmission among those infected with the virus. And the AIDS epidemic cannot end without the needs of people living with HIV and determinants of health vulnerability are addressed. Now, the National Agency for the Control of AIDS is expected to carry out this mandate, which includes coordinating the various activities of HIV and AIDS in the country. So how has the agency fared in sustaining the fight against HIV and AIDS over the years? You ask, how can we as a nation achieve the sustainable development goals and AIDS response of leaving no one behind with rights to health, gender equality, human rights, employment and social protection of those infected? Sustaining the fight against HIV and AIDS in Nigeria, that's our focus on Platform today. And my guest is Dr. Gambo Gumel Aliyu. He's the Director General, National Agency for the Control of AIDS. Thank you very much for joining us, DG.
Thank you. Pleasure to be here.
All right, so let me take you quickly through a brief of his profile. Dr. Gambo Gumel Aliyu, before his appointment as DG NACA, served as Country Director for the University of Maryland Programs in Nigeria and Assistant Professor in Epidemiology and Public Health at the University of Maryland School of Medicine. He was among the first Nigerians to receive in-depth trainings on establishing ARV PMTC CT Centers of Excellence from IHV UMB preparatory to the introduction of PEPFAR programs in 2003. Over the last 15 years, he was vastly involved in HIV research and program evaluations to support decision making. In 2005, he co-pioneered mobile HIV testing service delivery to key affected populations in the process of implementing an HIV seroconversion study. That's a research, that's a rich project in Nigeria. In 2017, he evaluated 2 national HIV treatment program strategies, Test and Start and Community Art, critical to scale up of ARV treatment for achievement of sustainable HIV epidemic control in the country. Well, he also directed the nationwide implementation of NAIS, that is Nigeria AIDS Indicator and Impact Survey, the world's largest HIV population-based survey in Nigeria, which helped the country to know the true epidemic and impact of HIV services delivered in the last 15 years of PEPFAR intervention and the last mile for achieving epidemic control. So you could say the right man for the job, and you will not be wrong. Thank you very much once again for joining us.
Thank you.
Well, your profile, very impressive. And
thank you.
All right, so let's also welcome our panelists, the head of health desk for NTA, Rabi Abdallah. Thank you very much for joining us, Rabi.
It's a pleasure to be here, Ruth.
Okay, so Dr. Aliyu, 15 years, NACA has been there trying to contain or control, rather, the spread of HIV and AIDS. There's been a lot of efforts we've seen, but in sustaining it is a huge task, you agree with me, because this is one virus that has been in existence way beyond 15 years of NACA's existence. So what would you say was our level of progress so far?
Thank you, Ruth. NACA is 14 years. We're not yet 15 years. Next year, February, will be 15 years.
Okay.
And HIV has been around for the last 40 years. And we have about 1.8 million people living with HIV in Nigeria. That's our estimation based on the survey you talked about. So far, so good. For the last 14 years that NACA has been coordinating the national response, we've seen changes. We've seen a drastic reduction, in terms of prevalence. Okay. And when we say prevalence, what we're looking here at is if you have everyone, like every Nigerian, gathered in one place, and you close your eyes and pick at random. You pick 100 people at random, and you test them for HIV. What we were seeing years before, at the time when NACA came on board, was that you can have 4 or 5 people out of that 100 that test positive for HIV. Now, if you were to repeat the same thing, if you close your eyes and pick, you have 1 person out of 100 testing positive for HIV. So that's the impact. From 5 out of 100 to 1 out of 100. And what we are hoping to achieve is that we go less than 1 out of 100, which means the denominator now will have to change. We're not going to be saying 100, but we say out of 200 or about 300 or 1,000, you may find few individuals, which when you convert to one denominator, it will be less than 1.
But would you pin that to the number of persons who readily make themselves available for testing? Because it's not something someone would just wake up, I'm going for HIV test.
It's a combination of so many things.
Okay.
1, the programming. 2, the fact that Nigerians have accepted the programming. And 3, Nigerians have, over time, learned to overcome stigma and discrimination. Before, if you meet individuals and start discussing HIV, they run away. And now you see individuals and you ask them, have you tested for HIV? And the individual will tell you, yes, I did, maybe 3 years ago. Yes. And maybe probably maybe willing to even share the outcome, which is not supposed to be, actually. Yes. Maybe willing to share the outcome and say, yeah, my test was negative. So you see, there has been this tremendous shift in terms of the way people see HIV and the way people see program for HIV and the way people respond to HIV programming. So at this material time, we have reached a stage where the majority have responded, and we have gotten very nice outcome. And now we are pushing for the last mile. And as I described it the other day, pushing for last mile is like you're pushing a boulder, let's say the HIV boulder, up the cliff. Mm-hmm. And by the time you approach close to the tip of the cliff, it will become heavy. And you may need additional hands to push it up and keep it there. So we're about that.
Okay, DG, let's look at the evolution now. A whole lot of interventions have been put forward that saw us to where we are today. Like you rightly mentioned that at the beginning, the period of stigma, when stigma was high, people were living in denial, and that affected, the response in so many ways. Right. But today, the story, the narrative has changed. Let's look at where we are today, because we're more or less like at the last lap. Yeah.
Right.
What are those things, because I said evolution. Based on where we are and people's awareness, understanding, government's proactiveness and all of that, what are those, gaps that we must close for us to get to the promised land?
Excellent. So some of these gaps that we must close, we must reduce new infection. The rate at which HIV is being transmitted is still unacceptable. We must reduce it to the barest minimum, where we're approaching what we call zero transmission. And we must reduce death from HIV. We've achieved tremendous progress in terms of reduction in the number of people that are dying of HIV and even the number of cases you see in occupying hospital beds. But we need to do more to make sure we take that one also, dying from HIV or death as a result of HIV/AIDS, to the barest minimum, towards zero. And that is the direction at which we're moving. But when you move in this direction, you realize that there are critical elements, or there are key aspects of your programming, which is very robust and broad, and it goes to different age group, different community, different setting of people. Here I can say prevention of mother-to-child transmission is one of the key challenges that we've seen now going forward. And apart from prevention of mother-to-child transmission is the programming for adolescents and young person. And these are the people who call AYP. So these are critical population groups. The adolescents and young person, we realize the problem is connection, to understand. The way we connect to adults and the way we connect to the other population groups where we make services available at the hospital. And we come on telly and we have program and people listen and they key into it. These individuals are usually on WhatsApp, Twitter, Facebook, and the rest of it. And they respond to a specific group that they identify. So until we key into those groups and we program together with this group, we may still find ourselves a little bit disconnected from this particular population group. But for mother-to-child transmission, we realize that we have for long lost an opportunity, and that opportunity is the community. You understand? Our programs have done very, very well in the community, and that is one thing that has come out of this COVID thing, that several countries globally, have found their HIV program to some extent negatively affected by COVID-19. However, Nigeria has emerged as one single country that has done exceptionally well in terms of HIV program in COVID-19. And what did we do? We went out to the community. We left the hospital. Okay? We left the hospital for COVID. We went to the community to look for individuals, and we were lucky to harvest something that we haven't done in the past, we haven't seen. On average, every year, we identify like 50 to 60,000 individuals and bring them to treatment. The last 19 months or 20 months or 2 years, with COVID, we were able to identify 350,000. 350,000 individuals and bring them to treatment. And this brought our gap, to a very small margin in terms of reaching or arriving at that critical bridge. And that critical bridge is 95, 95, 95. What this means is identify 95% of people that live with the disease. They should know that they have HIV. And 95% of those who know they have HIV, you should successfully place them on treatment and keep them on treatment. And 90% of those who you successfully place and keep on treatment should do well on treatment. That is, the treatment should be working. And if the treatment is working, what the treatment does is that it makes this virus disappear from the blood. And once this virus disappears, one, it doesn't get transmitted to another person. So these are the source of HIV in the society. The people that have HIV are the people that give HIV. So if you get them and you deny them that opportunity by introducing them to this medication and wiping out the virus from their system, and the virus doesn't show, they don't transmit.
Okay.
And good thing at the end is not only they don't transmit, the virus doesn't kill.
Okay.
Doesn't kill them.
That's why I'm going to take you up on the issue of pre-exposure prophylaxis and post-exposure prophylaxis.
Okay.
I don't know how much attention are we giving that time. It was when we really gave it the hype it requires, because especially in the era, this era of rape.
Okay. Yes. So the post-exposure is where the rape issue will come in, because if somebody is exposed to somebody who has HIV, now the exposure has already taken place. What do you do now is to quickly prevent an infection from setting in, and as well as health workers that work in the hospital, and for whatever reason they got exposed to someone that has HIV in terms of the fluid of that person, especially the blood, you now give certain medication to make sure that HIV does not establish itself in that individual.
It's antiretroviral, right?
It's antiretroviral. And the same medication you give when you have the pre-exposure. And the pre-exposure is the most critical thing now that we pay attention to. And this, especially for discordant couples. One person in the relationship, or the husband is HIV positive, the wife is negative. The wife HIV positive, the husband negative.
Which
how
we
do they
see all
remain?
the time.
Yeah, so how do they remain for the rest of their life like that without the other partner having HIV? So this is where the pre-exposure prophylaxis come into play.
How does it work?
It works by making sure that this medication deny HIV even if it shows itself access into the body system, and if it gets there, deny it instant opportunity to establish itself. Establishment here means that once it gets into the system and it gets into the cells that it affects, it goes and take over, commandeer the DNA, the individual DNA. And once it does that, it attaches itself to the host DNA, thus the damage is done. So what this drug do is to deny that opportunity, to deny it access into the system. If it gets into the system, deny it access into the cell where it's going to establish itself.
Okay, but let's say knowledge is power. Let's look at the adolescents and young people, the AYP you talked about.
Right.
A lot of them, people who are in that range, there's this inadequate knowledge and limited access to reproductive health services. Now, how do you bridge such a gap, especially with the case of rape Rabi mentioned?
So this is what we're figuring out.
Okay.
There was a statement their group made. Last 2 years I was in Kigali, and they looked at me and said, well, we've heard all what you say, but we want to tell you one thing. There is nothing for us without us. There is no program, whatever you do, for us without us.
Yes.
I told them I got you. Okay, so we're going to figure out ways where we do programming with you, and we use your representatives. Meaning the organizations that youth-based, that usually these individuals respond to or they key into. We do programming with them. So when they see them and they see what these guys symbolize, they now identify with it. But if they see someone like me, you understand the gap in age, whatever, the connection may not be there. But if they see somebody 15 years, 20 years, 17 years, coming to tell them something, and something that they have not heard before, or something they have heard before but misinformed about it. Yeah, so we believe and we thought that this probably will help us get through and will establish the necessary connection for our program to be accepted by this group.
It's good you mentioned earlier that it's not a death sentence, it's just the fear. People get scared to just go to know their status.
Right.
And it's one thing to know your status, and it's another thing to refuse to go for treatment. We see that happen all the time. There's this category of people who know, but they don't want to go for treatment. How is NACA dealing with that?
It all revolves around stigma. It is stigma that prevents people from testing. It is the same stigma that prevents people, after they've tested and found the HIV positive, from going forward to take medication. Some of it has to do with the facility that providing these services. Some of it has to do with the fear of health worker, yes, knowing about his or her HIV status, and this health worker knows this person. As soon as this health worker knows that this individual has HIV, the patient doesn't trust that this health worker will keep that information.
Yes, confidentiality.
Confidentiality will protect his privacy and confidentiality. And this is what we're working, to address, even among the health workers. Show them that protecting privacy and confidentiality is very, very important. It can lead you to jail if you don't do the right thing. If you do it wrongly and you let somebody's confidentiality or privacy, inappropriately exposed, and the person takes you to court, that you can actually be jailed. So this is the area, and this is what we're talking about, for the last 1 year or so, that we have alternatives. Okay, if you have fear of going to test for HIV, you can actually do this test yourself. Take it to your home, do it. We have self-test. You can do it yourself and find out your status. If you find that status is positive, call us. We have a hotline, 6222. Tell us about it, and we can tell you where to go and take this medication and get enrolled without anybody knowing.
I'll take you up on the self-test initiative, but
right.
let's address the issue of funding here, because whatever intervention, whatever attainment of target we're going to make, or accommodate more people under treatment and all of they all revolve around funding. And I know that for a pandemic that is mostly donor-driven, it's been so. I just want to know how, even though I know the country had made concerted efforts to take ownership to some extent, how are we doing with that? Where exactly are we? What sort of funding
investment
locally?
Right. So the investment is huge. Countries are not expected, not only Nigeria, countries globally are not expected to take ownership, overnight, because the money is huge. However, one of the strategies we've agreed with our donors, which principally largely is United States government and the Global Fund, is that we can on incremental basis, begin to absorb the cost, especially like of treatment. Last year we started with 100,000. Before last year we were doing 50,000. And last year we did 100,000. This year, because of COVID, we pleaded with our development partners to understand that we may not be adding additional 50,000. However, we will keep it at 100,000, but next year we will add 50,000. So as the time goes, and on yearly basis, we are adding 50,000 onto our treatment. And this is the government side. However, we also sourcing support from private sector, which we've seen private sector has done very well with COVID-19, the COVID. So it's something similar to COVID. In fact, our own has been, in the pipeline before COVID-19 struck. This is the HIV Trust Fund. And the trust fund is now established. A chief executive has been recruited, and that chief executive is busy trying to establish a secretariat and recruit persons that are going to support him, to drive this donation-driven organization, if I can call it that way. It is supposed to be private sector driven, and is supposed to appeal and raise fund for HIV, and this fund is supposed to be invested as soon as it is raised. Part of the proceeds will now be made available, to us in terms of commodities, basically drugs and kits.
Are the drugs free, just for clarity's sake?
Yes, these drugs are free, and we intend to continue to make them free even after our principal donors have ceased to be around with us. So that's the initiative. That's why we're bringing in the private sector, and also government is stepping up its commitment. So we're doing well on that, because the president has promised that from the year 2020, we will start reaching 100,000, and we fulfill that promise. We made available drugs for treating 100,000 individuals, and we made available kits for identifying additional 50,000, whom we're going to add this year to the 100,000. But we are looking at the funding now we have because of COVID, and we are appealing with our donors for them to understand that this year we may not do up to 150, but we will maintain the 100,000. Next year, we will make sure we have the additional 50, and we continue.
Your outreach, does it involve rural communities? Because most of these people live in ignorance. You know, some of them don't even know they're living with the virus. So how do you, bridge a gap like that if you have to keep up with the margin you're trying to breach?
Our outcome involve rural community, involve all communities that are high risk. The study you're talking about, the NIAs, help us to localize this infection, to know areas, and communities that are having the highest or the higher burden, and identify them and make sure we target them, saturate them, to make sure the individuals carrying the disease, all of them in that community are identified, and all of them are placed on treatment, and that treatment is sustained in such a way that that virus is kept under check in them. For communities that don't seem to have the infection, what we do is prevention, education, awareness, to make sure that they are on board with us, that they need to protect themselves from HIV, and especially pregnant women. When they are pregnant, it is very, very important during that pregnancy they test for HIV. They have this responsibility.
So why they go for antenatal?
Yes, so this is what we see. If they come for antenatal, fine and good. If they don't come for antenatal now, the strategy
which we see happen all the time.
Which we see happen all the time.
Yes.
So this is where now we're changing the way we provide this program. We will now reach out to them. For them, that we understand and we respect the fact that some people don't want to come for antenatal visit for whatever cultural biases or whatever. However, you come to antenatal or you don't come to antenatal, make sure you test for HIV. The kit is there. We can give you can test yourself, and husband can test his wife, a wife can test herself. And if both of them cannot do, the traditional birth attendants that most people use, these people that don't come to hospital have an alternative means. They don't allow their wives to deliver just like that. They make sure that in one way or the other, either a matron that is in the neighborhood, is called upon to take the delivery, or a traditional birth attendant. We won't use the matrons, the traditional birth attendants, the community groups that are within the community and can identify pregnant women and can see them. Most of them will be female, actually, going households and identifying pregnant women. Once they see them, they ask them, they don't attend antenatal. Okay, even if you don't attend antenatal, this is important. This package is for you. You need to know your HIV status if you don't know in this pregnancy for the sole purpose of protecting your unborn child.
Okay, DG, sir, you have been on the saddle of leadership for quite a while now, and I know that right from when you assumed office,
right,
you had your what do you call it now? You had your interests. You knew what you were bringing to the table for one who had been there even before you got to that leadership level.
Right.
What were this your priority? Because I know that the HIV self-testing initiative is to your credit. It's during your tenure. You're going to educate us, give us more enlightenment on what this is all about. Because you've just explained an aspect of it, and that got me wondering. Accuracy. What about that sense of hope, that sense of falsehood? If just in case one doesn't get it right, and you just go to town with that, sense of falsehood that you're clean when you're not, when you're negative when you're actually not. Maybe something went wrong somewhere.
During the testing.
Yes. How do we avoid that? What do you have in place?
Right.
To checkmate that?
Usually when we introduce self-testing to individuals, there are usually cautions that go with them. One, even if you test positive with the kit, it's not confirmatory. When you come to a facility, we're going to subject it to another form of testing, different from the one you did, to make sure we're sure. We're sure that, yes, the individual has HIV. If for any reason this is a false positive result, we'll be glad to tell the individual that do not worry. Sometimes when you do these tests, because of certain things that could happen, you know, the test could go a different, or because of certain things that are in you, especially places where they do this HIV vaccine trial, where they put these small proteins that are belonging to HIV, but they're not HIV. If you have them in your blood and you take this test, it's going to test positive, but you actually do not have HIV. Until we isolate the virus, we see it, we may not be sure that you have HIV.
So the test kit is 50-50? You still have to...
It has more than 50-50. Okay. It has that sensitivity and specificity that is about 98, 99, okay. Which means it's very broad in terms of its ability to catch, but one thing that matters with it is the predictive value. What is the probability that if somebody tests positive, this person truly has HIV? Yeah, so they have very good predictive values, most of them. So when we see it, if it is positive, there is that tendency that it may be false positive. Yes. At the same time, it may be negative, and the individual may still have HIV, but that is very, very rare. Once it catches, it's either it gets a kind of a protein, you know, that it's not HIV, but it's testing for HIV. But if the individual has something close to HIV, the test will pick it.
You know, I want us to look at the issue of this stigma discrimination, because from what Rabi just mentioned, we've seen cases where people go to a laboratory to get tested for HIV and the test results are mixed up, you know, and the trauma. It's very traumatic when you know you're living with HIV. Even if you know it can be managed, you just know the virus lives with you for the rest of your life. Now, I know recently NACA signed a memorandum of understanding with Human Rights Commission now to protect the rights, you know, of persons living with HIV. Part of your understanding, is it going to involve protecting the rights of persons, or, you know, or fighting for the rights of persons who may have been misled in such instances? And also look into the issue of where employers, you know, sack employees because they're HIV positive. We see that happen all the time.
This is a very valid point you are making. And this is the more reason why people living with HIV/AIDS or people who test HIV positive shouldn't be stigmatized and discriminated against. One, because just for having a laboratory test, there are so many things that will follow before we are sure that this individual is HIV positive and has the disease. Picking up that test and starting to stigmatize or to tell some other individuals that Mr. A tested positive for HIV, and, you know, the whole stigma machine now is put into play, you know, is very unfortunate. Yes. Very unfortunate in the sense that if we know that somebody could test positive for HIV without having HIV, and even the person that tests positive for HIV and has the disease, this person needs help. It is the help you give this person that will determine whether this person gives HIV to another person or not. Yes. So you have responsibility to help fight HIV, not to work for the virus. If you stigmatize and discriminate against, guess what? You're working for the virus because you're helping the virus. However, if you do the opposite and you help this individual and you give this individual the needed support, and that support include protecting his privacy. Yes, you know that I'm a health worker and this person tests positive for HIV, and I assure this person that nobody will know, and he should feel comfortable with me knowing not any person other than myself will know, and anybody who knows will know in the course of providing services and no more knowledge. You know, these are things that should even begin actually with us, the health workers, healthcare providers, making sure patients are reassured. And for people outside the health cycle, especially at home, it is important if somebody in your house is infected or affected by HIV to give them the necessary support to fight the virus and keep the virus within this individual. Don't let the virus out.
Let's have you do a self-appraisal now. Like I said earlier, you had your priorities, upon assumption of office.
Right.
What would you say you've been able to do, and what are you looking forward to offering Nigerians in terms of our national response?
Excellent. When I came, actually, if you're talking about my goals in office and the rest,
yes,
those goals have been predetermined globally by UNAIDS. United Nations Program on HIV/AIDS have already, set targets, and those targets by 2025, countries should attain this 95-95 we're talking about, and by 2030, we should globally end HIV/AIDS. So, how do you end HIV/AIDS? And you end HIV/AIDS by identifying people that have the disease. If you don't identify everyone, you identify a minimum of 95% of them, which means 95 out of every 100 that have the disease, identify them, and make sure you keep the HIV virus in this individual. It doesn't leave them and it doesn't kill them. So, coming back to your question, my goals, as I have been saying, and I've been sharing with our development partners, I have only two goals. And two words: control and sustain. You understand? One, control the epidemic, and two, provide structures for sustainability to make sure that HIV does not come back again. And that sustainability is what we have started putting in place now. The fact that we are now taking ownership, the fact that we are bringing on board HIV Trust Fund, you understand, to help us, provide resources or provide commodities, to fill the gap, that will exist when eventually our donors, cease to be available. And also to make sure the state governments now drive the program. They are in the driver's seat. For the simple reason, 95% or 90% of patients that we treat them in facilities belonging to state governments. So 95% of those patients are patients that are belonging to states, you understand?
Yes.
So the patients belong to states, the facilities belong to states, 95%. The human resources for health, the people that provide these services, are also staff or employees of state governments. There can never be sustainability without putting the states in the driver's seat and giving the states the necessary support and assistance to drive this program.
Are they showing the sort of commitment expected of them?
Big question. Yes, to some extent, some have shown commitment, and for others, we're still talking, and we will continue to talk to make sure that we have kind of an agreement and understanding, and we go beyond that to sign memorandum of understanding. What we're proposing is that if you have 10 patients in your state that have HIV, right now we are treating 100 of the 10 of them, all of them. So what about this arrangement where you state treat 2 and we treat 8? Let us begin with that. Okay, you treat 2 out of 10 and we treat 8 out of 10, and we continue. And this is something that we believe every state across the country can afford to do that.
Where is the place of the local governments in all of this?
The states are supposed to be the support to the local governments. The local government structures are there that we have because, we have the National Agency for the Control of AIDS. We have state agency for the control of AIDS, and then we have local government committee or whatever for the control of AIDS.
Okay.
We call LACA, and the state we call SACA. If you look at these facilities that we're talking about, if you go to a state, 90% or 100% of all the secondary facilities that provide services for HIV belong to states.
Yes.
So where local government may come, perhaps probably is the primary health care if that unit is now given to the local government. If it is under the control of local government and programs are there. So this is where we are now focusing to be visible at the primary level, care level, where at least screening, the antenatal screening is done, and other screening for HIV is also done at the primary care facility. But in terms of treatment and in terms of continued care and support and the test we do, those ones will have to come from the secondary facilities and tertiary facilities.
Okay, when you were just explaining all of these, a lot was going through my head. It's a chain. If you have to interlock this, the strings
right.
to breach the margin or reach whatever success level you want to reach as a nation. Yes, to get a target. Yes. Now, for us as a nation and you as a DG NACA, it's a huge task ahead of you.
Right.
What would you say it's the biggest burden, you're foreseeing? Yes, we've recorded success, but how do we sustain? Because you talked about control and sustaining this progress. Do we have the capacity as a nation?
So
Sorry,
the biggest...
that's a rider to that question.
Right.
The last conversation from Mr. President on our national response was more or less a directive. He said, eliminate HIV and AIDS by 2030. Big order. So
right. We will do. We will end AIDS by 2030. We are on track. We have done exceptionally well in the last 2 years, and we're hoping the milestone for 2025, Nigeria will achieve it next year. The 95, we see light at the end of the tunnel. By the end of next year, or even before the end of next year, we're very hopeful that we will tell Nigerians that, yes, the first critical milestone for ending AIDS is achieved, and that HIV is now under control. The next one, which you shared, is the nightmare I do also have, and that's sustainability. Commitment from state is very, very critical, it's super critical.
Yes,
the
because
federal
the collective
government, yeah, it's a
responsibility.
collective responsibility. Federal government has less than 10% of this. But federal government now is taking 100% of responsibility, as at now, which is not supposed to be so. So, cooperation, state ownership, state contribution is super, super critical. And we're looking at all avenues that we can appeal and that will make case to the state governors, for the state governors to see the need and the importance of taking ownership and the importance of taking HIV control in their hand.
So are you saying this revolves around advocacy? Can't we take it, beyond advocacy? It's a responsibility that must be, be taken up.
So if you take it beyond advocacy, then you're looking for laws, to enact laws.
Which is not going to work, because individuals still have rights to
exactly.
live their lives.
I'm talking about the commitment on the part of state governments now. I'm not talking about individuals.
This is what we've started having discussion with some state governors, and they're very open to this. In fact, one of them told me, Doctor, if we don't support 2 out of 10 of the patients you treat, what else can we do? We should be able to do that.
That's for those ones who are ready to key into it.
So we are very hopeful that the majority, or all of them, will key into it. Contributing 20%, of the money that is used to treat your patient, you know, and your constituency, I don't think is too much. And if we're able to achieve that and to get that, you know, agreed and that provided, then now I can say, yes, I can sleep with my two eyes, you know, that yes, we can do it and we can sustain. Okay. But until we achieve that, I still have that fear.
All right, what about the aspect of research? I know you're very particular about that. If we're looking at part of interventions to control the spread of AIDS and HIV and AIDS in Nigeria.
We are doing. We've just concluded research among the key affected population who are actually the drivers of HIV transmission now in Nigeria. You see, the prevalence among general population is around 1.3, and in some places you find 0.6, 0.4. However, when you look at key affected population, you will see 20% somewhere, 5%. The least you see is 5% among this group. We just concluded a study, you know, to figure out, one, where are they located in the first place? What program do they like? How do they want us to deliver the services to them? You know, all these are important. And, you know, how could they share some kind of information, you know, about their knowledge and attitude in terms of how they see HIV transmission, how they see prevention of HIV transmission, and how they see the use of preventive measures, including the pre-exposure prophylaxis.
Well, the LGBT group, you know, I don't know. It's something in a cocoon that we don't really, you know, I don't know. You understand what I'm saying?
Right.
What are we doing? You know, because they exist.
They exist, and we have had tremendous success in reaching out to them and programming. Let me give you an example. When I came on board, we had like 5 places where we give these services to them. And these are services that are given Benue-based services. At Benue, they trust and they feel comfortable taking these services. As I'm talking, we have over 60 of those one-stop shop, we call them, where we provide their services, and they are responding. And that is why we're making the success we're making. That's why HIV prevalence and transmission is plummeting. And we will continue to do that, and we will continue to work with this group to ensure that we've saturated that group before the end of next year.
All right, we'll round it off right away. I need you to tell Nigerians, you know, this fight is a collective responsibility, like you've rightly stated, and it involves that individual who is carrying that virus or living with it and not transmitting it to the next person. Right. What is your message to Nigerians as regards staying safe?
That Nigerians, Nigeria and Nigerians have done very well in fighting HIV, and we have given HIV the fight it deserves. And this momentum should be sustained. And everyone is a stakeholder. One thing you will do today to help us and to help the nation and to help your loved ones is, first of all, to know your status, especially if you know you're a risk taker. And the second one is that if you know your status, and unfortunately that status is positive, there is light at the end of the tunnel. Things have changed. HIV no longer kills. Come, we will keep HIV in you without HIV harming you, without HIV showing in your face, and without HIV killing you. At the same time, without letting HIV to leave you to affect your loved ones.
And what about the consciousness of knowing that not me, but the person is living with it, and you're not scared of what may be in the future?
Yes, you see, if we work as a team, and if we work, you know, with the same conscience that, yes, even though I have this virus, I will not want to give another person, and I will do everything it takes to make sure that nobody gets it from me. And I don't have this virus today, I will make sure I remain negative for the rest of my life. That's the responsibility that we all need to take, and that's the contribution we solicit from Nigerians.
So the message of stay safe does not apply to just COVID-19.
Indeed.
HIV too, two
HIV.
viruses.
Yes, in fact, we have been saying stay safe, for the last 40 years, and we will continue to say stay safe.
Thank you very much, Dr. Gambo Gumelaliyu. Thank you for your time with us. We'll continue to support NACAR in any way, talking about NTA, to ensure that this awareness is created.
Thank you. Thank you, Ruth.
Thank you.
We're grateful.
And thank you very much, Ravi Abdallah, Head of Health Desk in NTA, our doctor, in-house doctor.
Oh, thank you for having me.
Thank you very much.
Thank you.
All right, so we've been looking at sustaining the fight against HIV and AIDS in Nigeria. You never can tell. Just make that move to go get tested, to know your status. Knowing it is not the end of the world or your life, but the start to living right. And that's Platform. I'm Ruth Aguele. Bye.
wannan labarin ma yana peji na 36.
Ita kuma babban labarin wannan jarida shine ainihin
labarin da ke gaban jarida shine ta bayyana cewa
ọkwa ọjị ikenga eziokwu
nwanne m nwoke
Ikechukwu Ndukwe Igbo
mam iji wee mee ka ụbọchị na-aga n'anya ya
ọjọ́ léwútẹ́lú nù.
Nation fún ti òwúrọ̀ yìí ibẹ̀ náà ti sọ pé àwọn ìgbìmọ̀ aláṣẹ ìpínlẹ̀ Benue pàṣẹ wípé.
ní gbogbo àwọn ẹ̀ka ní ẹ̀ka ètò ẹ̀kọ́ ní ẹ̀ka ètò ìlera ní ẹ̀ka ètò ààbò.
there's a start and get. Promises to Shara. Winds up that right hand. Archbishop of basketball, goal! He hung on that net like a stalk up a tree.
NTA Sports 24 brings you all sports, all time and all day. Tune in to watch NTA Sports 24 on Star Times Channel 270, Star Sat on Channel 434 and